Good day, friends, and a warm welcome to this edition of 4D, that is detailed discussion and dialogue in diabetes, in Indian diabetes. This is season 3.0, and we are going strong. We are going strong because actually, diabetes is such a dynamic disease, it always seems to have something new up its sleeve. If on one day you are learning about glucose control, the next day you have a challenge of kidney disease. The third day, heart failure comes into the picture. And if this was not enough, we have a new complication, a new confounding factor, that is obesity. So in 4D, detailed discussion and dialogue in diabetes, let's discuss about obesity and diabetes. Let's have our experts with us today. A warm welcome to the dynamic Dr. Abhilash, who is a nephrologist working at Adur and Thiruvella in Kerala. Warm welcome, sir.
Thank you, sir. Thank you, sir. At the outset, I would like to thank Sun Pharma for giving me this opportunity. And I would thank our Sanjay Kalra sir, who is such a senior person, dignified person in the Endocrine Society. It's a pleasure, sir, to have you here, sir. Yes. Thank you, sir.
The pleasure is mutual, and greetings to you from doctors from across the country.
Thank you, sir.
We also have with us Dr. Arya. Madam is a cardiologist working in Thiruvella. Warm welcome, madam.
Thank you, sir. Thank you so much. Thank you, sir, for this opportunity.
And to complete the trio, we have Dr. Ramya. Madam is a very well-known endocrinologist working at LAP in Kerala. Warm welcome, Dr. Ramya.
Thank you, sir. Thank you. Thank you for the intro.
Our topic for today is diabetes and obesity. So let's talk about all these things. Dr. Abhilash, which are your favorite films? Do you like English movies or Malayalam movies or Bollywood? What's your favorite?
Sir, I like all kind of movies, sir. But usually I follow Hollywood movies. But it's not like that. I like all movies. Yeah. It's not. I'm not like language.
How is obesity portrayed in our movies? Would you want to compare Hollywood and maybe Malayalam movies? How do they portray people who live with obesity?
Yeah. Speaking of that, sir, we have Malayalam actors who are more obese compared to the other Hollywood actors. So I would think it is better portrayed in Malayalam society or Malayalam films, sir.
That's true. A similar kind of situation we used to have in Punjabi movies as well. So, yes. So the discussion is that it's a prosperous state. That is why the actors are well-to-do, like they are well built, they are stocky. But Dr. Arya, in Malayalam movies, the kind of leeway that men get, so your best actors are actually a bit on the plumpier side. Is that freedom allowed to the lady actors as well? Or for them, are the rules different?
Quite different, sir. Most of them are put into the comedian character. So that characters are being much given. All the elderly characters are given to them, I should say, of late. But that was not the scenario previously. In the older generation movies, it was not. It was almost, they also had a similar, we used to have Sheelama and that kind of, that era, that was almost, they also had got a leverage on that. But these days, it is quite different. Ladies are being portrayed on a slimmer side, size 0, not up to size 0, but we go for that. But then the hefty, that part goes into an elderly category of portrayal of leading roles, otherwise into a comedian character. That is what I observe, sir. Yeah.
So when we are discussing obesity, suddenly we realize that there is a societal issue and there is a gender bias as well. So, Dr. Ramya, this is the gender bias within Malayalam movies. And now all of us who are listening to this podcast, we all realize, yes, in our different states, there have been different stages of evolution. But would it be possible for you to compare the various industries, maybe Bollywood with Malayalam movies, maybe Tamil heroines with Malayalam-speaking heroines? Do you feel that there are changes and issues in the way we perceive obesity?
Yes, sir, definitely yes. That is when we, or in any film for that matter, when they portray a good character, I mean a good character in the sense of heroine level, what way they portray it is it should be a very slim, beautiful looking lady. Whereas on the other side, towards the villain characters, they will be portrayed in a different manner. Even in serials, we can see those villain characters are portrayed as very plumpy or obese women. But I should also say that now newer movies are being they are being approached in such a way that obesity should not be considered as a bad thing. Like we should, that means it should be even that it is, that is, as we doctors, we know it is not just obesity as a cosmetic side. Not just it is bad, but we are looking onto the metabolic side. That is why we say this is not good, or that is what is approachable. It is because of the metabolic concept what we are expecting.
That point is also well taken. So obesity can be a villain actually, but then what we realize is obesity can be a victim as well. So Dr. Vilas, speaking from a nephrology point of view, there are so many things to talk about. So let's structure our questions. The questions will be same for Dr. Bilal from a renal perspective, Dr. Arya from a heart perspective, and then Dr. Ramya from a metabolic perspective. So let's take the questions together, but we will answer one by one. Is obesity the villain in kidney disease? Can it cause kidney disease? Can it cause heart disease, metabolic disease? That would be one question. After that, we will ask in the next round, can kidney disease cause obesity, or the management of kidney disease? Do you use drugs in kidney disease and heart disease which can worsen obesity or adiposity or in metabolism? And the third would be, how does obesity affect us as a nephrologist? For example, how difficult it is to do a kidney biopsy. How do I know? Though, of course, my training was in nephrology, Dr. Vilash. My SRship was 1 year, and I would have done more kidney biopsies than clamps, perhaps, during my DM degree. So I certainly remember those days fondly. But is it more difficult now to do a kidney biopsy in an obese person? That would be our third round of questioning. Yes. So let's start with this. Is obesity the villain in kidney disease?
Yes, yeah. So coming to the first part of the question, yeah, obesity is definitely a big villain, sir. Actually, as we all know, obesity was considered as a prime risk factor in the causing cardiovascular disease and metabolic diseases. But obesity was never known, or it was not that much highlighted to be a driver of a CKD, sir. But coming last 20 years, recent data and a lot of data which has been published had showed that one data like the Framingham offspring study, a post-hoc analysis shows that each unit increase in BMI has led to a 1.25 times fold increase in the CKD incidence. And yes, sir, that is what these obesity. That is what. So obesity has several. Obesity causes CKD in several ways. It can be in the direct ways and the indirect ways. Indirect ways we all know because of the diabetes and hypertension. And the direct way, because mostly due to the hyperfiltration injuries. So there is a hyperfiltration injury causing due to the increased metabolic demand because of the obesity. So this hyperfiltration injury causes a state of chronic hypoxia in the renal tubules because of the mismatch between the demand and the supply. So because of this chronic hypoxia, there is a RAS activation. As you all know, RAS activation, hyperactivation causes an increase in the sympathetic drive and an increase in the intraglomerular pressure. The intraglomerular pressure in turn causes the glomerular permeability increasing and a glomerular leak, which causes a proteinuria. So that is one of the most important risk factor or a pathology for the CKD cause. The other causes mentioned are like the imbalance between the various adipokines like the leptin and adiponectin, which causes the oxidative stress and the inflammation. And this third mechanism will be a direct lipotoxicity happening, which causes a mitochondrial dysfunction because of the accumulation of fat. Also, the accumulation of fat, as we're speaking, in the renal tubules and the renal fat sinuses causes a compression of the kidney. And the fourth mechanism would be hyperinsulinemia and the insulin resistance, which causes the increase of the insulin growth factor increase and the TGF beta, which is a driver for inflammation and fibrosis, which eventually causes a nephron loss, accelerated nephron loss, glomerular injury, and tubular atrophy and interstitial fibrosis, driving the CKDs.
So obesity, yes, carry on.
Yeah, and the second question you were asking.
We'll come to that. Yeah, we'll come to that. So, but overall, obesity actually has a mechanical impact on the kidney directly, and it also makes the kidney age faster. Not only the glomeruli, but also the tubules. They age faster, and then there is greater load on the blood vessels.
Correct.
So when we speak of the blood vessels, Dr. Arya, the blood vessels and heart are considered together. So is obesity the villain in heart disease? And is it also a villain in vascular disease per se? And vessels would be lymphatics, arteries, and veins, all three of them.
Yeah, sir. Thank you for the question, sir. Yeah, exactly, sir. It's a like very pronounced, very big villain, I should say, from my point of view. So starting from the, it's like affecting in a mechanical way, as you told, the structural way, the also the electrical way, from my cardiac point of view, and all the ways it's being affecting. So one by one, regarding the endothelial dysfunction, as we all know, it causes the damage to the endothelial dysfunction, causing on to the hypertension, right? The increased BMI, the increased waist circumferences, as we all know, the metabolic syndrome, causing the hypertension, which is very important. Starting from, especially this is important in Kerala scenario, because most of our children are obese. So starting from the school age group, we have this hypertension being affected directly because of the obesity part. Coming on to the cardiac part, so it causes a structural change. So what happens is that the LV remodeling the left ventricle is being affected. The LV hypertrophy occurs, LV remodeling occurs, the LV stiffness occurs. So we have the LV end-diastolic pressure so much increased, so that the LA pressure also increases. That again causes the pulmonary venous pressure to go up, and the patient develops the symptoms of, as we all know, the heart failure with preserved ejection fraction. So what is that? The patient will be having, as we know, patient will be having the same symptoms of heart failure, but will not be having a reduction in the ejection fraction. However, patient will be symptomatic, but there occurs a dilemma in the diagnosis also. So NT-proBNP is the one which helps us in the diagnosis here. But again, there is again a paradox. Obesity, patient can have a decrease in the NT-proBNP levels. Not that usual cutoff of 220 is not, as we know, it is not the marker which cannot be always got in an obese patient. So again, there is a diagnostic dilemma coming up. But thankfully, we have got echocardiographic parameters, which again helps us in supporting the diagnosis. So always it is a clinical diagnosis to go on with. So we have to, again, that is the heart failure with preserved ejection fraction. Then again, coming to the electrical disturbances of the heart, we have the arrhythmias, which is coming up in a way. So this kind of a remodeling occurs in now these days the studies say that the epicardial fat is there. Epicardial fat releases out the markers, fibrotic markers, which causes the atrial fibrosis. And because of these atrial fibrosis, patient can develop atrial fibrillation also. So in these patients, that's one reason. Obesity again is causing electrical disturbances in these patients. So, and also, as we know, in when the LV pressures go up, also this arrhythmias can happen. So there is heart failure with preserved ejection fraction happening, there is arrhythmias happening, there is hypertension happening, and as we all know, the other secondary risk factors come along. The diabetes, as Sir has rightly mentioned, the other risk factors for coronary artery disease come up along in obese patients. So that we get myocardial infarction in a younger age group of our patients. And we do see many patients coming up with MI, which is a very sad part of it. And peripheral vascular disease also occurs. That is also there. So these are the observations from my side, sir.
So we'll take the vessels later, but what we understand is that obesity impacts the structure as well as the function, the electric function and the mechanical function of the heart.
Yes.
So many things, Dr. Ramya, and we see that obesity is the villain for much of kidney disease. CKD is an epidemic now. Heart disease, unfortunately, the more we try to fight it, the worse it becomes. And obesity is one of the reasons why, even though we have such good quality drugs in cardiology, we are still not able to have an impact on morbidity, even though mortality has come down. Premature mortality has come down. What about the metabolic side of things? Does obesity directly cause or confound metabolic and endocrine disease?
To answer that, I should say that obesity management has become a part and parcel of most of the endocrine diseases we are dealing with. One, to start upfront from even in the upfront, one is diabetes. Diabetes, as we know, the obesity, or specifically I would like to say visceral adiposity. The visceral adiposity is a fat depot, and which will chronically release the free fatty acids into the circulation, which can all the way worsen the dyslipidemia status. And as Dr. Abhilash sir has said about the adiponectin and leptin, the adiponectin is a molecule which is being released, which will reduce the insulin sensitivity. So, and leptin resistance is a picture what we see in obesity, wherein the leptin levels are high, but then it is resistant. Then apart from that, hyperinsulinemia is always a part of obesity. And so that is how the diabetes, not only the diabetes, this hyperinsulinemia can cause water retention. It can affect the IRS pathway, I mean the insulin resistance pathway, and can produce hypertension, increases the sympathetic activity. So that is about the diabetes, hypertension, dyslipidemia. Apart from that, PCOS we have. This PCOS, obesity, insulin resistance, it has been a vicious circle where the weight reduction is an important part of that management of PCOS. And apart from this, I should also like to mention about the hypogonadism part also. That is, I think I have started feeling that a good number of children presenting with delayed puberty they are all found to be obese. It could be related to the MOSH, the male obesity secondary hypogonadism. So in almost every aspect of the endocrine diseases we are dealing with, obesity has become a part and parcel. That management has become more important these days.
Dr. Ramya, thank you for pointing this out. The term that we use now is OARS, obesity associated reprosexual syndrome. It is important to know about this because, like Madam said, obesity will impact not only reproductive but also sexual functioning. And many times in our community, we are not able to get patients who get treated. You are not able to find a motivating factor. When you talk to them about obesity, and then you talk about OARS, obesity associated reprosexual syndrome, in both men and women, in in boys and girls as well, in adolescents, then suddenly the family and the individual gets motivated to seek treatment for obesity, and they are able to help their overall metabolic health. But Dr. Abhilash, we've been now talking about obesity like a villain, and the poor little adipocytes, which also do create good kind of hormones like adipokines, they say that we are being victimized unnecessarily. The adipocytes say that we are a victim of nephrology treatment. So is it possible in nephrology, can you have iatrogenic obesity, or can you have iatrogenic redistribution of fat?
Yes. In CKD, sir, as we know, they are engaged in polypharmacy. There are a lot of drugs CKD patients, at least 10 to 15 drugs on average, or 8 to 10 drugs they might be having. The typical patients might be getting OHA medicines, antihypertensive medicines, and antidepressants, and antipsychotics. All of these are commonly implicated in the development of obesity. Especially antipsychotics like the second generation or atypical antipsychotics like the olanzapine, they can cause obesity. The tricyclic antidepressants, they can cause obesity. Then the antihypertensives, especially the beta blockers, like the first generation and second generation. It's not very much common with the third and the fourth generation, but first generation, second generation, latinol, propranolol, even metoprolol, they can cause obesity. And even the OHAs like glipizide, glyburide, and insulin, they can also cause obesity. So there are a lot of causes, medications that can cause obesity. Yes, sir. And even certain patients with CKD, they might be on steroids because of the underlying autoimmune disease. They can cause obesity. So there are multiple drugs or polypharmacy that is engaged here.
From a post-transplant perspective, we have a question from Dr. Saurabh Sharma, who is Associate Professor Nephrology at Safdarjung. He says, from the transplant perspective, any drugs that can be a cause of obesity or edema?
Yes, even the post-transplant medication, especially the steroids which we're taking, high dose steroids, they can be initially they will be on high dose steroid like 60 mg. They will be pulsed with steroids. So steroid itself can cause obesity. The tacrolimus which we take, that is the immunosuppressant, they can cause an obesity in an indirect way because they are prone to diabetes or NODAT, new onset diabetes after transplant. Because of that, they can have a metabolic dysfunction and obesity. So these are the common drugs implicated in the post-transplant periods.
Dr. Bhupinder Singh, who is HOD cardiology at AIIMS Bathinda in Punjab. Dr. Arya, Dr. Bhupinder Singh points out that there is a very thin line between edema and obesity. The term that he uses is obestasis. So people with obesity have more of stasis, they move less, and that can present as edema or edema-like feeling. So the question, madam, is what are the drugs that can cause edema? Cardiac, non-cardiac, and when you have somebody who has got swelling of the feet, how do I figure out, whether it is venous, whether it is lymphatic, it is arterial, what do I do with a person who is obese and who has edema? How do I review the prescription as well, first of all, to find the iatrogenic causes?
Okay, so first of all, we have to see the most common, as we all know, it is the calcium channel blocker amlodipine itself. So it's as Sir has rightly pointed out, there is a thin line between. And then we have to review the drug chart and see whether the antihypertensive medications itself first of all. And then we, from the cardiology aspect of view, we give amiodarone, lots of amiodarone has been given, which can again cause hypothyroidism, which can again cause a fetal edema. That is also there. So then, apart from that, there is a vasculitis treatment. We usually give steroids. Steroids again can cause edema, which again has to be looked into. So that is again there. And as we have been taught from our school, we have to first of all depend upon whether there is a cardiogenic cause of edema rather than depending upon the ejection fraction. The echocardiogram has to be looked into and see whether there is a pathological cause first of all, looked into the echocardiogram, and then only you also have to assess that also along with this I was telling, and then look into the nature of the edema, whether it is a pitting type of fetal edema or it is a non-pitting type of fetal edema. Whether it is a lymphedema, means it is more or likely it is non-pitting type of edema. Then there is in the elder vasogenic type of edema will also be present in case. Mostly it is the drugs which we see right and left. It is the amlodipine and amiodarone, hypothyroidism causing agents, as well as these steroids which is causing in our practice which we see, sir.
Some of the other drugs that may be culprits can be pregabalin, which can cause edema.
Yes, sir. Yes, sir. Yes.
Another very interesting drug interaction occurs when you give a DPP4 inhibitor and an ACE inhibitor. When you give an ACE inhibitor, it inhibits the breakdown of substance P or bradykinin. DPP4 also breaks down substance P and bradykinin. So when you inhibit that, then again the breakdown is lost. So giving two inhibitors together, which is so common, giving a prescription of maybe perindopril along with, let us say, vildagliptin, which is so routine, this can actually cause edema because you have inhibited the enzymes which are going to break down substance P and bradykinin. So these are also common reasons. In general, if you have someone with edema, try to look at the prescription again and again. And for all of us, I'm sure all of us who are here will agree with me, the more we read basic biochemistry, pharmacology, the more we need to learn more. So we should keep on reading about basic pharmacology as well while we are in practice. Dr. Ramya, any other situation where obesity becomes the victim? Any drugs that we use in diabetes or maybe in other endocrine diseases where you end up causing a different kind of obesity?
One thing is, I should start with steroids. Glucocorticoids, as we know, they produce a visceral fat. The adipocyte differentiation, it can cause visceral fat accumulation. Then, as we have discussed, the insulin resistance part, and per se obesity can be a part of that. Then coming to the diabetes drugs, other than what we have discussed now, other than that, one is insulin. Insulin itself will cause weight gain, and also most of our patients will be dumped with on insulin, like 40, like more than 120 units per day. Usually, the patients with insulin resistance may require such a very high dose, which is a very common cause of, weight gain. Then coming to the female reproductive part, the oral contraceptive pills. And for that matter, other than that, the estrogen supplement, which we give for the sexual dysfunctions, hypogonadism part, that also can produce, that can cause weight gain. Then about the sulfonylureas. Sulfonylureas again can produce, they basically produce hyperinsulinemia, which is a ultimate cause for weight gain in them also.
Pioglitazone would be another drug, and sometimes in endocrinology and even in nephrology for that matter, we are guilty of giving very high doses of calcium and vitamin D. So there also you will find that when you are over enthusiastic in treating osteomalacia or rickets, then you end up with the rickets part becomes okay, but the young girl ends up with weight gain, and then it's very difficult to shed off those extra kg. So it's a good idea to go slow. So we have seen now that obesity can be the villain of diseases, but it can also be a victim of what we are doing. But always we are talking of person-centered care. And Dr. Abhilash, now you've been in practice for so many years. When somebody comes in, a senior nephrologist or physician comes and says, you must be person-centered, you must be patient-centered, it's all okay in theory, but sometimes you do get tired. So it's not a bad idea to be physician-centered as well once in a while. How does obesity impact you? in 2 decades of experience now in the medical profession, has the obesity epidemic made it easier for you, your life as a nephrologist, or do you find new challenges which you had never thought of when you were training?
Yes. See, sir, as you said, obesity has become a challenge for us, because why, as practicing nephrologists, we face various difficulties. For example, when we try to cannulate a patient, we put a central line or put a permacath for the patient. It becomes very difficult. Getting an access will be extremely difficult. So that is one important point. The next important point would be the diagnostic challenges when you face, because getting a proper BP cuff for such obese patients, it's very difficult, and it's not available most of the times in our clinic. So measuring BP is a huge challenge. Along with that, getting a CT, MRI, most of the machines might not be compatible with such heavy patients, because the machines might not be accommodating such patients. So that is one important point. And the next is the pharmacotherapy. Many times obese patients have different pharmacodynamics because of the increased hepatic metabolism and increased and the altered volume of distribution. Many of the drugs, we don't get an intended effect when we give such of medicines because of the increased volume of distribution. This comes to the transplant medicines as well. The immunosuppression might not work properly in post-transplant cases, and we have to keep adjusting the immunosuppression medications. So these are the challenges as a nephrologist I face. So there are the other challenges as well. So speaking of that, there's increased chance for sleep apneas, depressions. In a dialysis patient, there are a lot of other complications, delayed wound healings, increased incidence of POVDs. There's just so many to name, sir.
That's true. And then the patient ends up being dissatisfied with us, and they will blame us, but they will never blame the obesity that they had come presented. Dr. Arya, is the same thing true in cardiology as well? What are the challenges that you face as a human being, as a cardiologist, when you have someone who is super obese?
Yes, sir. As sir has told, hypertension is there. We do our majority diagnosis from echocardiogram. So to get a window, it is very difficult. It's always a suboptimal window. So most of the views we have to compromise. In assessing we do try our maximum. So we have to press our probe very deep, because pain to them very deeply we get the views. So it is very difficult to get a view in such a patient. Then suppose if you're taking up the patient for the procedures, so directly, as I has told, put in the puncture. So we are going to take a femoral axis. So always we take it on the bony mark, preferably. X-ray fluoroscopic guidance is there. Ultrasound guidance is there these days, but in a case of an emergency situation happening, in a case of an acute MI, very difficult to get for the pulse also. Sometimes it can cause very dangerous complications like retroperitoneal hematoma. That should be very careful, but still it can happen that is there, very obese patient, and the patient is lying on a very small bed. So there also, again, we hear a lot of complaints from them. So they can't turn this side, that side. We are doing the gap. They have to lie flat. That is there. So then, and after post-procedure, we have to advise them about ambulation. So we have a graded ambulation structured. So that also, the targets may not be achieved in such kind of patients very easily. We have to advise them. And sir has told about sleep apnea. So that makes a difficult diagnosis in heart failure with preserved ejection. We don't know. Patient present with a sleep apnea, heart failure also, this goes in mimicking. So we have to make a correct diagnosis, differentiate between these two. So that kind of difficulties we do face. Yeah.
And we should spare a thought for our nursing staff as well as the orderlies who bear the brunt. A nurse who is herself weighing just 40, 45 kg, she is expected to take care of someone who is 150 kg. So it's tough. So we should spare a thought for them as well.
We ask them to push the abdomen so that we get a very good puncture. It's difficult, sir. And the patient itself is they might get irritated also. We have to keep them at comfort zone.
Great. And Dr. Ramya, in endocrinology, if we could go starting from, because we have all physicians from across the country, so people would be interested in knowing right from hypothalamus pituitary down up till the gonads, how does obesity impact us? I have a patient with hypothalamic obesity. Will my patient be satisfied with me or not? I have a patient with hypothyroidism and obesity. What does the patient want and what am I able to offer? So just one by one, could you go through the glands and talk about it from your point of view? How does it hurt you in the OPD? Or how does it challenge you in the OPD during obesity?
One is when I talk about this hypothalamic obesity, I could think of these small children or towards the teenagers where they present with craniopharyngioma having hypothalamic involvement, where this part will like the patient will be having this hyperphagia part as part of the involvement of hypothalamus. Other than that, with adrenal insufficiency, we are putting on steroids to that patient. That will again worsen the system, and and in fact we don't have much to offer to such kind of people. Then in the thyroid part, every person coming to the OPD, if he or she is an obese patient, will attribute everything to hypothyroidism with a very stable TSH. And I'll repeatedly say, even just a 2 to 3 kg of weight can only be attributed to hypothyroidism. We cannot say every or that much amount of weight is because of hypothyroidism. And how much I explain, they will never accept. They may be on thyroxine with very well controlled TSH. They will never accept that their obesity is not due to hypothyroidism.
That's
Then the diabetes, then as a whole, sir, the diabetes and its complications, including the osteoarthritis part. The people, we advise them to go for exercise. They will, the moment we talk about exercise, they will say, I can't walk because I have knee pain, I have ankle pain, back pain, I can't walk at all. Like that, they will start the so this joint, their mobility as a whole is affected by obesity, secondary to articular part, or even otherwise the vice versa also. This will worsen. This will continue as a vicious circle.
And these are actually multiple issues. And then to add to that, the impact on fertility and sexuality, that is another issue. So in general, the obese person will be dissatisfied with the endocrinologist in general, and no matter how hard you try, like Dr. Ramya said, you are not able to explain to them that the issue is weight loss. Now, of course, we have newer drugs which are a bit more economical, so things are better for us, but still that the counseling it's always an uphill task. The more obese the patient in your OPD, the more time you will need for counseling, and the less satisfied they go out. Is there an issue with investigations as well? So like Dr. Arya, she mentioned about NT-proBNP, but Dr. Abhilash, what happens to albuminuria? What happens to EGFR in a person who is obese? And what is cystatin C for our audience? Will that help in diagnosing kidney function in a obese person?
Yes, sir. So there are ways to assess the kidney function, which is a calculated GFR, which is mentioned as the EGFR. Sir. So EGFR can be calculated using the creatinine as a tool or a cystatin C as a tool. So there are benefits with both of them. So the problem with creatinine is it's muscle dependent. So more is the muscle mass, more will be the creatinine. Hence the EGFR measured according to creatinine will vary. But here comes the advantage of cystatin C. Cystatin C won't vary with the muscle mass. So there is an advantage with that. In malnutrition, sarcopenic obesity and all, better tool would be the EGFR with the cystatin C. But the problem with the cystatin C, it again varies with the adipose tissue and the inflammation status. So it is not a very good tool in assessing kidney function with patients with obesity. So the better tool would always be a urine protein creatinine ratio or a urine albumin creatinine ratio. The problem with again CKD, CKD itself is a pathogenic risk factor for development of CKD. The other problem with CKD, if patient with CKD has an accelerated fall of GFR with the patient has obesity, the fall of GFR will be more rapid when compared with a patient of CKD without obesity. So that is another problem with obesity.
So we should be aware of these, and we should always interpret on the side of caution. If you have someone who is obese, maybe our threshold for referral to a nephrologist, that threshold should be lower, which means that you refer at an earlier stage so that they are able to pick up the subclinical dysfunction.
Yes, sir.
Dr. Arya, you do so many echos, and we speak about obesity. Of course, some obesity is overt. We are able to diagnose by looking at the BMI. But there is something known as normal weight obesity. The weight is normal, but the patient has got too much of visceral fat or ectopic fat. And here actually the best quality study from India has come from Kerala Diabetes Prevention Study, which showed that half of Kerala was lean, half of Kerala was obese, but in that lean, 50% had got normal weight obesity, which means they had high visceral fat. And when they followed up these people for 10 years, they found out that those people with normal weight obesity also had cardiovascular risk, high CV risk. So we should be able to pick them up. The simplest way would be a waist circumference. But Dr. Arya, madam, when you are doing these echos, is there actually something called pericardial fat or epicardial fat? Are you able to see it? And could you just describe it to someone like me who has never done an echo in his life?
Sir, yeah, we are able to see the epicardial fat, sir. It is just like a ecoduscent, it's a black color, you see, it's just like a black color. It is like a black color which we are able to see. Normally it mimics a like pericardial effusion also. So we do have differentiation between both. So you are able to see the what do you say, the over the cardiac we are able to see the markers. Epicardial fat is, that is the usually epicardial fat which is responsible for the, which is the one which is, as sir has mentioned, responsible for the lean obesity. And also, sir, as I previously told, we are also able to the obesity complications with the preserved ejection fraction, other markers are also there. So the left atrial volume index is there, the LAVI as we say, we have to look for that. If there is there, patient is developing diastolic dysfunction, we have to go in for that also. We have to see the tricuspid valve velocity is also there. So these are the things which we can indirectly point out that the patient is having a diastolic dysfunction, and also there is epicardial fat, sir. About the study, sir, I'm not that authoritative in telling that.
Okay. And Dr. Ramya, so now we see that obesity is so closely linked with the heart. It is also closely linked with the kidneys. And Dr. Vilash didn't tell about the left versus right kidney. So we assume that it impacts both sides. But what about the muscle? And you spoke about what we call the Mohn syndrome, musculo, osteo, arthro, neuropathic. So when the patient comes to you with aches and pains, the patient is not telling you that I have a muscle disease or a nerve disease. He is coming with moans and groans, which can be musculo, osteo, arthro, neuropathic. If we focus on muscle, Dr. Ramya, what is this concept of sarcopenic obesity? And is it a new concept, or do you feel it has existed forever and we only just woke up now to recognize it?
Yes, sarcopenia. I have been. It was in fact my thesis topic about sarcopenia. My topic was in young type 2 diabetes patients. Young in the sense of between 18 to 30 years. So I do find sarcopenia in that age itself. And when we say sarcopenic obesity, apart from the obesity part, we say the fat mass is accumulating. At the same time, we are actually giving little importance to the loss of muscle, the muscle mass. So as we are talking about adiposity, we are dealing with agents like GLP-1 agents, which has come a very big way to reduce adiposity. And we have been using right and left now in the system. But then we should also know that there has been papers coming up that the GLP-1 are known to produce or it causes sarcopenia, that it reduces a lean fat. As it reduces adiposity, it is reducing the muscle mass also. So this sarcopenic obesity might have been a link, or it definitely has some role in the pathophysiological development of metabolic syndrome. But then I think this concept of sarcopenia as a whole is coming up only recently. That is not routinely, we don't evaluate for sarcopenia in every patient. When we see a patient, we in fact go behind the obesity part alone. And that becomes a very important issue, especially when we are dealing with elderly patients or such frail patients. That is obese patients, but with an underlying chronic health disease. And if we are going to target them with GLP-1, we do not know what happens after 5 to 10 years long-term treatment.
So we are learning about this now, and why the increased discussion is there because of the iatrogenic sarcopenia that is occurring with some of our medications. But if we treat properly, we should not face this challenge. Dr. Ramya, just on a personal note, my son recently completed his thesis on sarcopenia and type 1 diabetes, in young type 1 diabetes. Yeah, and he completed his GM just a few days ago at AIMS. He passed his exam. So your thesis topics are similar.
Yes, sir.
But we have a comment from Dr. Khyati. She lives in Kolhapur in Maharashtra. And she says, dear experts, Dr. Vilash, Dr. Arya, Dr. Ramya, you've been speaking for nearly 40 minutes now, and you've been talking only of problem statements. When will you come to treatment? We are then we have to treat. So, Dr. Vilash, let's come to you. When you talk about CKD, the KDIGO has all these pillars of treatment for CKD, and they are very well thought out. Even people in cardiology and endocrinology, we follow KDIGO.
Yes,
so, what is the focus on weight loss, on exercise? Would you want to speak from the guideline point of view and then
Yes,
talk
sir.
about what you do in practice?
Okay. So KDO has laid out a clear plan for the exercise schedules. So KDO says at least 30 minutes of exercise per day for at least 5 days in a week. That is 150 minutes per week. That is what KDO recommends. And the protein intake, it depends upon the stage of CKD. Sir. For early stages of CKD, like CKD 1 to 3, not much of a protein restriction is advised, but in late stages like CKD 4 and 5, a protein restriction is advised of a 0.8 gram per kg per day is advised. If the patient is on dialysis, it's a protein restriction, you should give extra protein, at least 1.2 gram per kg per day should be given for that sort of patients. And several diet has been mentioned, but one of the important diet is the Mediterranean diet, which has been proposed, but it's not mentioned in the KDGO. But Mediterranean diet says that whole food based on a plant diet. It's an important and it's a good diet to follow. That is what I don't know how much of endocrinology would be more an authoritative matter on this in this issue. So that is what the protein requirement says. Anyway, balanced diet is very important, sir. Balanced diet in the sense like 30 to 40% of carbohydrates, 30 to 40% of fats, and a 20% of protein with equal 30 to 35 grams of fibers. And a fiber diet should also be included in the diet plans. And yeah, that is what. So a tailored diet plan with the physical activity, that is more important, sir.
Dr. Arya, first Dr. Vilash made me very happy because when I come to Kerala, my favorite food is plantains. And I am very happy eating plantains breakfast, lunch and dinner, and I don't want anything else in life. But then he made me unhappy because he said balanced diet. And then, so how do I balance my plantains when I come next time? This is from a cardiac perspective. What are the do's and don'ts that you struggle with in your OPD? You're trying to counsel your patient to take more of this, less of that. And then the patient is like me, my phenotype, and he says, Madam, I am willing to sacrifice everything else, but not my fried plantains. How would you handle?
Yeah, fried plantains, sir.
They're very tasty, madam, actually. No?
Sir, yeah, I would suggest, yes, sir, as oil is a villain. Oil at high temperature is a very villain, as you said. So for cardiologists, it is always a fear. So what we say that any oil is like okay. But when you heat the oil to a very high temperature, the chemical nature changes so that it becomes harmful for your plaque, and the plaque erosion can happen for us. So what do you say? Preferably avoid heating oil to a very high temperature. That is very much needed. And repeated use of oils, as we all know, is again not advisable, be it any oil. So and that does in our kitchen, this happens. We use the excess of the previous day's oil for the next vegetable cooking and all, so that you can take it a 93 rule, as our HOD says. So 90 days you go on for a strict diet, 3 days you get off with it. That is what we say to our patients, but preferably avoid oil at a higher temperature. Then avoid your carbonated drinks, your red meat. That itself, red meat is also advisable to avoid. Then you start inculcating your this things, walnut and all, which is very good in HDL, which is increased in more in your diet. And then increasing portions of fruits, vegetables, and proteins, and reducing your refined sugars helps us in that is a diet which we usually incorporate. And then it has to be started from your kitchen. That is what we always say. That is, you have to be cautious in your, and also when you take care of your children, when you take them out, you have to prepare meals in that way. And when you buy some drinks for them, you have to look at the refined sugars when you give to them. That itself helps in bringing out their children in a greater way. That care has to be taken by the lady of the house. That is what more father also, but still. Then, sir, regarding the diet, as sir has already, exercise, as sir has told, we also, BSc guidelines also say 150 minutes per week. And we advise moderate intensity of exercise for 5 days. And for the 5 days is advisable. And occasionally for 2 sessions, we are also advising high intensity exercises. for a cardiovascular health. So that is what. And moderate intensity, we mean that we are able to comfortably talk while we are walking. So that means you can, provided in a very safe environment, we are able to use your headphones and talk to your friends and walk, or you can even hear your songs and then comfortably work. Not only walking, you can also do your cycling, your dancing, whatever it is. That is what we suggest from the BSc guideline for the exercise factor. Yeah. Thank you.
That makes a lot of sense, and it is so heartening to note that we are all speaking the same language with our patients. So we are all physicians from across India gathered here together. So whichever part of the country you are in, whichever specialty you deal in, we all speak the same language of exercise and diet to our patients, and it's a language of moderation, a language of good health. But Dr. Ramya, one specific question. It is said that people who use coconut oil more intelligent. This is the average opinion that we would have in Rajasthan and Haryana about states where coconut oil is the basic cooking oil. So they have longer hair, they are more beautiful, and they have more IQ. So that is one aspect, that coconut oil has a neurotropic effect, nootropic effect. And based upon my interaction with my colleagues with whom I've done MD and that is true. On the other hand, if you go to international literature, they create a demon or a villain out of tropical oils. So they will say, like coconut oil murdabad, palm oil murdabad, and they will also label it as a tropical oil, that these are not to be used. You use only oils which are grown in Canada, in the temperate tropics. Now, what is the truth and what would be the way forward? I come to you as maybe the homemaker for a family that is suffering from diabetes and obesity. I do not know how to cook with any other method apart from coconut oil. That is what my grandmother taught me. That is what my mother taught me. What do I do, madam?
Sir, coconut oil, as you have said, in Kerala diet, coconut oil is it is almost an indispensable part. We cannot cut off oil from our diet. So one thing is we can advise that we can divide the amount of oil being used in a family based on the number of members, and as we say, it is like 4 to 6. Saturated fat content, which is advisable for a healthy diet, is said to be less than 7%. And I should. To be frank, this coconut oil definitely contains more of lauric acid, which is more on the saturated. It is more of saturated fat, definitely, yes. Then apart from the oil part, there are also other areas where that is directly not the oil, but the coconut itself. When we say, we most of them say we use very little coconut oil, we try to reduce it, but the fact is that we will use more. Grated coconut is another area which our diet is mostly focused on. In almost all the side dishes of lunch, we use grated coconut, and the morning itself start with a chutney which is made of this grated coconut. Then we have the fish curry. Almost every curries which we make will add coconut in this grated form and also in the oil form. So the reduction, when we say about reduction, it should be a combination of all. It is not just the oil part. That's what I think.
And that is important. So you speak with your patient in a very empathic manner and tell them to reduce the total burden. And maybe we can also ask them to increase spices, because in our Indian kitchen, we are blessed with so many spices. So if you want taste, what you tell them is, why don't you reduce the oil, but you increase the use of spices, various types of spices, play with the leaves, play with the curries, and that will give you a tingling sensation in the mouth, in the palate. Dr. Abhilash, madam spoke about coconut oil. She spoke about grated coconut. But what about coconut water, potassium, the pluses and minuses? Could you speak to an all India audience? And for those who are not from Kerala, the further north that you go, coconut becomes more expensive, but it becomes most prestigious. So our patients will come and tell us with a lot of pride, I buy one coconut every day for my wife. It costs 100 rupees. But I am a very good husband. I give her coconut. The fact that her potassium is 6.5, that is immaterial. So would you speak to a national audience, sir, the advantages and disadvantages of coconut water?
Yes, sir. As we all know, coconut water is rich in potassium. So what it has been observed is, if you're not a CKD patient, and your diet should be containing of less of a sodium and more of a potassium. Because what happens is in certain tribal areas of North America and Peru, it was found out that certain tribal people, they were not exposed to salt. They were living purely on a plant-based diet, like fruits which are rich in potassium. They were not exposed to salt because they were not exposed to salt water, or they never had the exposure to salt. So their diet basically contained high potassium, low salt. And their median blood pressure was found to be just 170. So that is what the importance of a high potassium, low salt diet. That is what it can do to your blood pressure. But that becomes a problem. High potassium becomes a problem in, as we know, in CKD patients, especially in diabetes patients. What happens in long-standing diabetes? There will be a paradox, because there will be interstitial inflammation and fibrosis, and which leads to the destruction of the juxtaglomerular apparatus, causing a decrease in the renin. So there will be hyporenin, a stage of hyporenin, hypoaldosterone stage, hyporeninemic stage, so which can indirectly cause a hyperkalemia. So that sort of patients are more prone for hyperkalemia. And when it comes to these patients, especially long-standing diabetes, ends up in CKD, and they will be more prone for hyperkalemia. So that sort of patients we should never advise for a potassium-rich diet. So their diet should be spared of potassium.
So CKD, and especially patients who are taking maybe drugs like Finrenone or Spironolactone.
Especially they do those sort of things.
Dr. Ramya, from a calorie point of view, is coconut water a cause of disturbed glucose control, or is it not a major issue in your practice?
Coconut water.
Yeah, does it impact? I'm just asking. Does it impact glycemic control?
Yes, sir. It do impacts glycemic control also.
So is it seen frequently in the OPD? Do you have to proactively tell your patients to reduce coconut water if they have poor glucose control?
Not much, sir. We don't see people mostly frequently using that. That becomes an issue only when the patient is having some underlying diseases, when they are having some set of fever spikes or something like that. Some illnesses on and off, that is when those diseases wherein their intake becomes less, they will rely on such drinks as part of diet. Only on those occasions this becomes an issue. Not very frequently, I feel so.
And Dr. Arya, in a cardiology perspective, heart failure and coconut water, is that an issue in your practice, or it is a non-issue?
So not much of a kind of issue. One thing is that, as Ramya has told, majority of Keralites know when the patient is sick, the first thing which comes into their mind is this coconut water. From a very small age, when the child itself is sick, what the parents give to the child is coconut water. Just like porridge water, rice water which we get, the kanji water we call it. Just like that, the alternative for this is coconut water. The tender coconut water we have. So that causes me there is a thing in the treatment of heart failure. Again, my fluid content, I want always less than 1.5 liters, less than 1 liter per day. So again, there is a fluid challenge for me. Rather than that, as all the drugs which Sir has mentioned comes into heart failure management, that again causes hyperkalemia. But then, Sir, in real scenario, less controversies I have met with coconut water. Sir.
Not too much of controversy.
Not too much. Sir.
The Haryana equivalent of comfort beverage would be haldi wala doodh, which is turmeric milk. So turmeric milk will be given for each and everything under the sun.
Yes.
And in heart failure, here we get in trouble because the family wants to help the patient.
Exactly.
And the way they help is by going and buying the expensive coconut water. So let us say one uncle came, he brought one coconut. The other auntie came, she brought another coconut. The patient is forced to drink both, and then they'll end up with fluid overload or with hyperkalemia. So that is something that we see here perhaps more frequently. But it's been great, and I speak on behalf of everybody who is logged in with us in 4D. We have learned so much about obesity, diabetes, but more important, we have learned about how we manage these patients in our OPD. We are doctors, we are human beings, we face multiple challenges. And from the insights that we have gained from Dr. Abhilash, Dr. Arya, Dr. Ramya, I guess we are all strengthened now, more energized to interact in a more efficient manner, in a more empathic manner with our patients. Obesity and diabetes, it's not like a linear correlation. It's not Newtonian physics. It's more of Einsteinian quantum physics, everything interacting with each other, so many things. And the more you enter this cobweb of causation, this cobweb of clinical presentation, the more confusing it becomes. But the way Dr. Abhilash, Dr. Arya, Dr. Amy have explained things for us, it's become much simpler. We are more strengthened now and more enthusiastic, more enthused to go back to our OPDs tomorrow. So on behalf of everyone here, I'd like to thank all our experts. Thank you. Personally, on a personal note, it feels so heartening to see that our younger doctors, our younger nephrologists, physicians, cardiologists, endocrinologists are so confident, yet so human and humane. This combination of confidence and humanness, this we very rarely encounter. So 3 cheers for our 3 stalwarts today. Thank you, everybody.
Thank you so much, sir. Thank you for the insights.
Thank
Good
you
night.
and Jai Hind.
Thank you, sir.